Part 2. This Part 2 is going to pick up where we left off on Part 1, describing hypersensitivity and autoimmune diseases, and we're focusing now on the details around types 3 and type 4. I want to refer you back to the summary slide in the first part where we looked at 1, 2, 3, and 4 all on one slide. That was a great summary slide, so you may want to take a peek at that again. But what we need to do now is focus on the details around type 3 and type 4. What is type 3? Type 3 is uniquely different than type 2 in the sense that we form these immune complexes, an antibody and an antigen complex, and that floats around in the body and it gets lodged somewhere. Okay? So it actually gets stuck. It physically gets stuck. And you can kind of see some examples here of the deposition of these medium complexes. Those medium complexes, that immune complex collective body. It's the antigen and the antibody complex is called a medium complex. Where can it get trapped? Well, it gets trapped in places like the kidney. It gets trapped in blood vessels. And it also can get trapped in joints. And the reason for it is in kidneys we have a lot of filtration, and we have a high blood pressure that is pushing through the kidney to filter the blood. So it's pretty obvious that things will get caught there. In the blood vessel walls, usually it targets the smaller vessels because those vessels are going to be a little bit more susceptible to having things trapped in their vascular wall. And then in joints, because of the filtration that takes place to create synovial fluid, we also have a filter type of mechanism like what we see in the kidneys. And so it's another location where we see these medium complexes form. Okay, so the medium complex forms, it forms in the blood, and then it gets trapped in these sort of three classic locations. So up top, you can kind of see an example of how this looks. So these antigen and antibody complexes, the green little spheres are the antigens, and these little dimer Y-looking antibodies, that's the way we always draw them, right? They bind up to the antigen, and you can see that there's some agglutination taking place. This is starting to precipitate out now, and that forms a complex, and that complex can get trapped, for example, in this phase. And as it gets trapped, it triggers a vasculitis type of problem. Okay. So this is a type 3 mediated hypersensitivity. Now, the role of complement, as you can see here, is to facilitate this. Again, complement is a facilitator. It helps to facilitate different processes depending upon where it is. And in this particular case, you can see how complement is serving as a co-stimulatory event to that antigen-antibody binding complex. What are these clinical manifestations? Well, if that's found in the kidney, then we result in glomerulonephritis. If it's found in the joints, then we would call this reactive arthritis. Okay, reactive arthritis is different than rheumatoid arthritis. Rheumatoid arthritis we'll talk about here momentarily. That's a type 4. So reactive arthritis is different than rheumatoid arthritis, and reactive arthritis here is a type 3 hypersensitivity. And then the last one is vasculitis. Vasculitis is what we just characterized, what these three pictures are showing, if the clinical manifestation is in the vascular tree. Now, these aren't the only manifestations. They can happen in other organs. It can happen in other areas. These just happens to be the main classic ones that we typically see. So, switching gears to type 4, what is type 4 hypersensitivity? Type 4 hypersensitivity is considered delayed. It is cell-mediated. It's either going to use a CD8 or a CD4 pathway. And some examples include things like type 1 diabetes, transplant rejection, and, as we just mentioned, rheumatoid arthritis. So we'll look at some of these here momentarily. The cell-mediated response of hypersensitivity will likely initiate and activate effector CD8 and CD4 cells. The CD4 cells that get stimulated are going to move on and likely activate phagocytic cells. And ultimately, those phagocytic cells, in combination with the cytotoxic CD8 positive cells, are going to go out and destroy tissue. So you get CD8 cytolysis via apoptosis. You get phagocytes releasing lysosomal enzymes and creating reactive oxygen species in the tissue. And so you get a lot of tissue destruction. Okay, so you can see in the top panel an example of type 4 where you have CD4 and CD8 cells involved. We're triggering inflammation to take place. Okay, and then down here with the CD8 mediated cytolysis, later on these CD8 cells are actually specifically targeting the tissue and causing cytolysis via the apoptotic mechanisms. So let's look at a couple of examples of type 4 hypersensitivity. So this example here is actually contact dermatitis. Contact dermatitis is a result from exposures to certain types of antigens, okay, that's uniquely different than an IgE-mediated response, which is a type 1 hypersensitivity. Some other examples are Crohn's disease. Okay, Crohn's disease is thought to be an autoimmune disease which attacks the gastrointestinal lining and causes inflammation or a type of inflammatory bowel disease. And we believe that this falls under the category of a type 4 hypersensitivity. MS, multiple sclerosis, this is where the fatty myelin sheaths around axons of the brain and the spinal cord are actually targeted and damaged. It demyelinates the axon. It causes a wide range of different symptoms and problems, but many of those have to do with neuronal pathways and the speed at which the action potential can take place. Diabetes mellitus type 1. In this type 1, also known as juvenile diabetes, this is an autoimmune disease where the insulin-producing beta cells of the pancreas, the beta islet cells, are targeted and destroyed. And they no longer can make insulin, and therefore it increases blood glucose levels as well as glucose that's found in the urine. And then the last one on this list of a classic example of a type 4 is Hashimoto disease. Hashimoto disease is a unique scenario where T cells are destroying the thyroid cells in the thyroid gland, and so the production of thyroid hormone plummets. It drops. Two others that aren't on the list here that need to be mentioned. We talked about rheumatoid arthritis, and we're going to get to that here momentarily. We'll talk very specifically that there is a certain type of antigen in the joint synovium, and we believe it might be type 2 collagen, and that's what the antibodies are being, or that's what the cells are actually targeting. Again, type 4 is not an antibody-mediated response. It's a T-cell mediated response, CD8 and CD4, and so the antigen in rheumatoid arthritis of type 2 collagen is specifically being targeted by these T cells. And then the last one on our list is a type 4 with celiac disease. Celiac disease is a condition that affects the linings of the small intestines, and T cells are thought to attack something within that lining, and it causes a inability for the absorption of certain nutrition. A lot of times this is due to a reaction after eating gluten or wheat or barley or rye and possibly oats in some circumstances. And so it may be an interesting classification where first off it's a food allergy where that's causing damage to the intestinal lining, and now that's exposing the intestinal lining and antigens to cytotoxic T cells and or CD4 cells, helper T cells, to stimulate this type 4 hypersensitivity that we see in celiac. Looking at transplant rejection, which is a another category, another example of type 4 hypersensitivity. Transplant rejection is interesting because we see it widely used across many different medical communities, and we have gotten a lot more sophisticated now where we can actually manage this. So what happens? Well, in type 4 hypersensitivity with transplant rejection, we get an incompatibility of the allograft. Allo meaning same species, so this is from one patient to another. And first what happens is you get the recognition of foreign cells. Okay, it's based on the major histocompatibility complex, and it can happen either one of two mechanisms. It can happen either a direct mechanism, which we're showcasing here on the left side. This is the direct mechanistic pathway, or it can happen via an indirect mechanistic pathway that's shown on the right. Now, with the direct recognition pathway, the host cells are directly going to recognize the allogeneic foreign MHC. Okay, so the host cells actually see that particular foreign MHC, and this is involving CD8 and CD4 T cells. And in the indirect recognition pathway, the CD4s see or can identify foreign MHC present in the host antigen presenting cell. Okay, so the host antigen presenting cell, or the recipient, the MHC complex is seen to be foreign by the donor's CD4 cells. So strategies that we use to mitigate or minimize transplant rejection involve immunosuppressant drugs. So how do these work? Well, let's back up a little bit to previous information that we've learned, and we're looking at a cutout of a lymph node. And this arrow that goes from T cells, CD8 positive T cell population, down to effector or cytotoxic T cells, we have this little call out box, and we can see this interleukin 2 co-stimulation pathway that allows for the production of the effector and memory T cells. Well, cyclosporin actually blocks IL-2. Okay, so cyclosporin, also known as cyclosporin, was originally isolated actually out of a soil sample in 1969. And it has this interesting activity in that it blocks IL-2. Okay, so the IL-2 being absent now is going to prevent cytotoxic T cells from being effector and memory cytotoxic T cells, and so they won't be able to go into the periphery and specifically target and destroy the donor tissue. All right, so how does rejection take place? Well, we get CD8 mediated cytolysis. We get CD4 type 4 hypersensitivity damage. We can also get some things where we start getting antibodies being produced, complement being activated, and leukocytes recruited to the area. We get thrombosis, which is the basically clotting of blood, and all of this is going to lead to vascular damage and eventually organ death. Okay. So in this histological example, we're looking at a kidney donor or a kidney allograft. Okay, so in panel A, in image A, is the early phases or the hyperacute phase of rejection of a kidney allograft. We're looking at endothelial cell damage, platelet and thrombin being present, and neutrophil infiltration into the glomerulus. Okay, so some of the things to highlight here, again, we've got early hyperacute phase of kidney allograft failure. The infiltration and the platelet presence can be best visualized by these areas right here, and here, and up here, and the neutrophil infiltration into the glomerulus. So at the level of the glomerulus, we're starting to see some increase in these purple nucleated cells that shouldn't be in this glomerular region. Now, if we look at panel B, we start seeing more inflammatory cells in the interstitium, right? So we're getting more of the purple nuclei in the interstitium, and also between the epithelial cells of the tubules. And then in C, we start to see some proliferating smooth muscle cells that take place right here, right? So this thick layer from about here to here, these are all smooth muscle cells that are actually starting to proliferate in the intima of the vasculature. And then lastly, in panel D, we're looking at arterial sclerosis. So the vascular lumens are actually being replaced by an accumulation of smooth muscle cells. So you can see the smooth muscle cell ring here that gets more prevalent, and it has proliferated to close off, and here is all that remains. That little sliver of white right there is all that remains of the lumen of one of these blood vessels in the area. Okay, so you've got arterial sclerosis of the vasculature within this kidney. And this is that vasculitis that we've been talking about that can take place in a rejection situation. All right, our last segment in this Part 2 lecture is going to be looking at some of these autoimmune diseases more specifically. Let's talk about some of the pathogenesis of autoimmunity. Well, a lot of times what happens is we get the breakdown of self-tolerance mechanisms. So we fail to screen via central and peripheral tolerance, and now all of a sudden we have these self-reactive lymphocytes throughout in the circulation. How can this happen? Well, some of these things are genetic, okay? And so there are triggers that are genetic. There likely can be some triggers that are environmental, and some of those environmental triggers may be things like radiation or exposure to certain elements. If we take a look at the picture on the right, is this genetic susceptibility, or whether it's an environmental trigger on this left panel, leads to the ability for self-reactive clones or lymphocytes to be in the periphery. They can move on and they can cause all sorts of types of infection and tissue damage problems as a result of their self-reactivity. Let's look at systemic lupus erythematosus, SLE. So there really are 4 different types of lupus, and this example of SLE, systemic lupus erythematosus, is a type 3 hypersensitivity. Now, the 4 types include SLE, also a cutaneous or a skin version only, a discoid type of lupus, and drug-induced lupus. There's also a fetal lupus that shows up and sometimes can resolve itself. The autoimmune disease involves nuclear antigens, and usually there's 2 initiators. There's both genetic as well as environmental stressors. Okay, so if we look at this slide, as we were talking about before, we have some inherited susceptibility genes that are obviously in play with this systemic lupus erythematosus type 3 hypersensitivity, but there are also some environmental triggers like UV light or irradiation. Sun exposure tends to aggravate lupus symptoms, and both of these collectively can cause some of these nuclear antigens to show up and activate B and T cells to these specific self-antigens and cause this IgG autoantibody production and lead to a immune complex mediated response. That's the type 3 process. All right, some of the morphologic and clinical features of systemic lupus erythematosus. We get what we call acute necrotizing vasculitis. That is where you get this antigen-antibody complex and it gets lodged into the wall of the vasculature. We get swelling of the joints. We get skin redness or erythema. We know that there may be a central nervous system contribution. Oftentimes we believe that this is due to vasculitis issues of the small vessels, vasculature, that is found in the nervous system of the brain. And so that might be why we see some of central nervous system disorders associated with SLE. And then lastly, glomerular nephritis. So you can see that in systemic lupus erythematosus, SLE, these patients suffer from the three main classic examples of where the antibody antigen complex gets stuck. It gets stuck in the vessels, it gets stuck in the joints, and it gets stuck at the levels of the kidney. Okay. In this young lady, this girl, this is called a Marlar rash, or otherwise known as a butterfly rash, because it bridges the nose and goes over into the cheeks. And involved in this patient, this is an example of discoid lupus, and it's really mainly just the skin. But SLE patients can have this along with all of the other things on the bullet points to the left. Okay, so this patient doesn't have SLE. She actually has a discoid or a skin-only version. But SLE is more severe, can have all the things on the far left, including skin erythema, which is what we're showcasing in this particular clinical image. Okay, rheumatoid arthritis. What is it? It's a type 4 hypersensitivity, and it's very common. It's about 1% in occurrence in the population. It involves helper T cells, and likely they're responding to some atherogenic agent, and we believe that this is collagen type 2. So these activated T cells are going to produce cytokines that activate macrophages in the joint space. They may actually also activate B cells, we don't know, and those B cells could be making autoantibodies. So we said that type 4 doesn't involve antibodies, but now we're starting to talk about some examples where antibodies may be involved, like with celiac disorder or celiac disease, as well as with rheumatoid arthritis right here. Okay, so we can see the play out of the antigen, and we said this antigen likely is a type 2 collagen. We get the involvement of CD4 positive T cells, and they have multiple actions. They can activate macrophages, right? And these macrophages can come in and cause all sorts of tissue damage that we're used to seeing. They can have activity at the level of the endothelium, and this endothelial activation can help to accumulate or recruit these inflammatory cells. We also see evidence of B cell activation and maybe the production of some other types of autoantibodies or a rheumatoid factor, and this can further deposit in the joint. And all three of these pathways lead to what we call pannus formation and the destruction of the bone in cartilage in that tissue. And so let's look a little bit more specifically at what is that pannus, what is the fibrosis that takes place, and what is ankylosis. So at the level of the joints, we can appreciate that synovial joint that's shown here in normal architecture on the left, and a rheumatoid joint, one that's susceptible to type 4 hypersensitivity on the right. You can see that the synovial membrane is clean here on the control, and over on the disease state we get this pannus ingrowth. That's a massive synovium and synovial stroma and inflammatory cells. There's granulation tissue that's present, fibroblasts that grow in, and eventually it surrounds that entire space and causes what we refer to as ankylosis. That's a Greek word that means crooked or bent or stiffness of a joint. So crooked or bent joint, leading to rigidity of that joint. And that's kind of the classic example of rheumatoid arthritis. At the level of the skin, we can see some manifestations, what we call rheumatoid nodules. They only appear in about 25% of the patients that are affected, and they arise in the skin. They're very sensitive to pressure. They're firm. They're not tender. They are round to oval in appearance, and they're found in the subcutaneous tissue. And they're basically like lesions, if you will. Okay, and at the level of the blood vessels, we can actually see some vasculitis that shows up in these patients. And if it's in severe cases where it's compromising blood flow to the peripheral extremities, we can actually see ulcerations or wounds in the lower limbs. We can see neuropathies, where if blood flow is compromised to nerves, then the nerves actually get starved and they get that pinprick feeling, that numb, tingling feeling that's really annoying when you like sit on your foot too long. So that can happen in these patients as well. The histology that we're showing here, in the middle histology picture, we're looking at a low magnification that shows the synovial hypertrophy that takes place. So in this middle, this synovial hypertrophy that takes place is swelling of that synovial joint. And so the gaps of white right here are really, really thin. And they should be really from white here all the way over to here. So most of this slide should actually be white space, but the histology is revealing that we've got synovial hypertrophy and we've encroached on that white space or that void space. So what that means is we're looking at histology like right in this area, and while it should look white and wide open, it's completely encroached on by all of the hypertrophied synovium. Now over in the far right histology, under higher magnification, we're actually able to appreciate lymph node aggregates. These are these lymph node aggregates that are showing up in the synovium. All of the red arrows are highlighting, and where my cursor is are these lymph node aggregates. And those are very similar to those types of nodules that we see in the skin. Clinical significance of rheumatoid arthritis. Many of you are rather familiar with this, but the organs that can be affected aren't just the hands. Okay, so this can be joints all over the body. Usually it targets small joints first, and then it moves to larger joints. We talked about the nodules in the skin. It can affect the vessels, like vasculitis that we talked about. That also can lead to vasculitis problems in the heart. We can have issues with lungs as well as muscles. We talked about ankylosis, meaning the stiffening or the bent nature of that joint. It can be episodic, meaning it can flare up and then it can subside. It is oftentimes symmetric, and this is very different than osteoarthritis, which is more of a bone-on-bone wear and tear. Rheumatoid arthritis is, we've got this antigen agent that is causing this problem, and in osteoarthritis, you basically have just worn out the joint, the cartilage is gone, and you're rubbing bone on bone, and that's causing some inflammation. And osteoarthritis can be on one side of the body. It could be unilateral. It could be the patient's left hip or the patient's right shoulder if they threw a ball for a long period of time, played professional sports, or they played college ball for a long while. That might lead to osteoarthritic conditions. Whereas rheumatoid is symmetric. It's going to attack both the right and left. It's going to be bilateral. Okay. In 80% of these cases, we can actually clearly identify an RA factor. But that means in about 20% of the cases, we kind of don't really know what's going on. this last slide is a summary slide, and it does a really nice job of wrapping everything together. It shows characteristics on the far left column, and then it lists out type 1, type 2, type 3, and type 4. You can see the different antibodies. Generally speaking, type 4 we say none because really it's supposed to be T-cell mediated, but I gave you a couple of examples like with rheumatoid arthritis as well as with celiacs that we do think that maybe there's some antibodies being produced in addition to T-cells being activated. You can see the response time on this row. You can see some of the appearance features. So wheal and flare. So wheal is a red swollen mark that's like left on the skin after a pressure or after someone gets struck. Okay, so this is kind of like redness, if you will. Okay, and you can see histologically, and then you can see how it's transferred: antibody, 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 1, 2, 3, and then classically T cells for type 4. Lastly, you can appreciate that they've listed some additional examples of the different types of hypersensitivity on the 4th row. So this now wraps up the second part of our hypersensitivity lectures. This was part 2 of 2. And we covered the different types of hypersensitivities. We covered the different autoimmune disorders. We gave a lot of very specific clinical examples. And then we dove uniquely into transplant rejection, systemic lupus, erythematosus, SLE, and rheumatoid arthritis.